Hello and welcome to this special podcast on the recent updates to the EULAR guidelines for the management of SLE. So this is a very important subject today. I'm Ed Vital from the University of Leeds and I'm chair of the Lupus Forum. And today I'm delighted to be joined by Professor Dimitrios Boumpas, who's a professor of medicine at the University of Athens, and he was actually the lead of the task force that updated the EULAR guidelines. So welcome, Professor Boumpas.
Thank you, Ed. It is great to join you.
So the aim today is to discuss the update, how it was done, and also to focus on what that means for clinical practice. So I'll hand over to you to go over the main changes.
Thank you. Please allow me to show you some slides, just highlighting why this was done, and the task force members, the overarching principles, and the statements, and briefly discuss them, and then this will be followed by questions and answers. So I guess the obvious question is, why should somebody update the EULAR recommendations 2023? And for two reasons. Because new treatment strategies and more ambitious goals of treatment have become possible, thanks to the new treatments being introduced, but at the same time, the realization that there is a need to streamline, simplify, and homogenize these recommendations to comply with the new EULAR standard operating procedures to facilitate their disseminations. Another important reason for updating this year is that always EULAR has tried to have international experts, but we felt that we had to increase the international presence in these recommendations. So we felt that we should, during this round of update, we should involve more people all over the world, and you'll see that this became feasible. So these are the members of the task force. As you can see, many Europeans, nephrologists, rheumatologists, nurse practitioners, patient representatives, but also people from Asia, from North America, and South America. So this is an international, indeed, task force. So these are the overarching principles for the new recommendations. First, we stress that lupus requires a multidisciplinary, individualized management with patient education and shared decision-making, taking into consideration the cost to the patient and the society for the treatment. We stress again that lupus disease activity needs to be assessed at each clinic visit and combined with evaluation of the organ damage at least once annually using validated instruments. We stress again the importance of non-pharmacological interventions, including sun protection, smoking, and so on. Then we said that the pharmacological interventions are directed and tailored to the patient characteristics, the type and severity of organ involvement, treatment-related harms, comorbidities, risk for progressive organ damage, and patient preferences. All these are taken into consideration. And finally, that early SLE diagnosis and regular screening is important, and frequent monitoring to assure adherence to the therapy, and these are essential to prevent flares and organ damage, improve prognosis, and enhance quality of life. And this is because data from all over the world suggests that the earlier the diagnosis of lupus and the more strict monitoring, the better are the outcomes.
So this is kind of suggesting a treat-to-target approach, really, isn't it? That we measure disease activity every visit, and target means disease activity and steroid dose that we have to optimize. Is that fair to say?
Indeed. So I guess what you're emphasizing is an important point. We don't have individual therapies. We have a strategy and with certain goals, as you suggested, and we try to portray this with these recommendations. These are just some data suggesting that although why it's important still to talk about the early diagnosis, because in many countries, including the UK, but all over the world, there is significant diagnostic delay, and which can vary. And this slide just highlights this. To this end, groups, including the group from George Bertchias in Crete, have devised and taking advantage of the SCR EULAR recommendation classification criteria, have tried to adjust them to start thinking of diagnostic criteria to estimate an SLE risk probability index. They call it SLE SLERP. We tried it in the internal medicine clinic. We found it useful, and they may facilitate the diagnosis of lupus. So without any further delay, this is the first statement. No surprise, talks about the hydroxychloroquine. The target dose is 5 milligrams per kilogram, decreases the risk of flare. At the same time, you have to take the retinal toxicity into consideration. And we discussed that in previous years, because the monitoring was not as sophisticated as is nowadays, we somehow were missing subclinical toxicity, and that's why it's important to target the dose of 5 milligrams per kilogram. If you exceed this dose, there is using sophisticated techniques, you may signs of retinal toxicity, and that's why we have to stick to this dose.
And I've noticed, I noticed that some of my colleagues are starting to dose by weight more than they used to, actually. That many people just used to use a fixed dose of 200 milligrams, but actually it's not appropriate for all patients.
I'm glad to hear that. So you have to take into consideration, I guess, hydroxychloroquine is a drug usually you don't discontinue, but at the same time, we try to emphasize that it's important to keep an eye on the retinal toxicity, and that you have to assess the risk for flare. There are some patients who have a higher risk, and the retinal toxicity with the longer use. Should we move to the next one, Ed?
Yes.
The second, of course, statement deals with the glucocorticoids. Glucocorticoids have been the cornerstone for the therapy of lupus, as hydroxychloroquine. But here, and this is a departure from the previous recommendations, we decided based on the data that the maintenance dose should be less or equal to 5 milligrams per day, the prednisone equivalent. And we also discussed extensively and decided that most of us agree that the use of pulses of methylprednisolone in patients with moderate or severe disease may facilitate the use of moderate and not high doses. And this is the recommendation which supports this. As you can see here, the evidence is very good. It's 2AB. And for the pulses of intravenous prednisolone, the data are not as strong, but the experts decided that may be useful. Ed, would you like to comment on this?
I mean, I just noticed that the target dose of 5 is lower than in some other guidelines now, isn't it? Because the LL-DAS criterion, for example, is 7.5 milligrams, but now we're saying no, preferably 0, but now 5, which I feel is very positive step.
And as we said, thank you. And as we said, we're doing this because now we have new drugs which allow us to decrease the dosage of steroids further while maintaining remission of low disease activity.
Yes.
Now, we're talking about the strategies, as Ed suggested. So in this statement, we suggest that the early use of DMARDs or immunosuppressive therapies or biologics can enable us to reduce the dose of steroids. And here is another important point. You do not have to cycle them. You don't have to necessarily use DMARDs or immunosuppressive therapy first. The EULAR recommendations give you the flexibility if you wish to go directly to the biologics based on the profile of the patient. Very often, we try the DMARDs first, and then we move to the biologics. mainly because of consideration of the cost, but at the same time, we felt that there are certain patients that you should be able to go to them first. And these biologics that we're discussing here are the belimumab and the anifrolumab, with very strong evidence for efficacy and safety from randomized controlled clinical trials. Ed, any comment on this?
And at the moment, I think that's very positive to be able to use the biologics first line. But at the moment, there are only limited ways that we can decide which patient should go straight to a biologic, or which patient should try an immunosuppressant first, or which of these options is the right one. Is that we have a few situations which are covered in some of the other guidelines, but we don't. For many patients, it's hard to decide.
That's a good point. And I guess just to simplify this, although this will come up again with the subsequent considerations, I guess the committee felt that each time that you have to use moderate to high dose of steroids, even if it's early in the disease, you start thinking of biologics from the beginning. And because the data are strong with the biologics, and also just, and I say that after many years of experience, like Dr. Vidal has, is that it's not clear the data that the methotrexate or azathioprine or MMF, the quality of the data are not as good as with the biologics. That doesn't mean that the notifications, but the data and the quality is not as good, although it's clinically, we use them all the time. So the bottom line is that once you start in a patient, even early in the disease, if you think that you may need moderate to high dose of steroids, start thinking of the biologics early, considering the prescription, what the local conditions in the country allow you to do, and the insurance companies.
Yeah.
The cyclophosphamide and rituximab are the two drugs that in previous recommendations were suggested that they can be used for, I'm talking about the high-dose cyclophosphamide and the rituximab for patients with refractory disease. The Eurolupus pulse that was pioneered by people in UK and in Belgium has shown that it has very good results and limits the toxicity. However, we felt that few patients with severe disease they may need cyclophosphamide, and at the same time, during the last the past few years, rituximab was becoming increasingly popular. After the COVID epidemic, we became more familiar with the risk for delayed clearance of the COVID, of the slowly recovering COVID. So that's why we thought that, and because rituximab is not available, it's not approved for lupus, and in many parts of the world, cyclophosphamide is cheap and it's available, we thought that we should not forget an important drug, and just put this statement, which says that in patients with organ or life-threatening disease, intravenous cyclophosphamide should be considered. In refractory cases, rituximab may be considered. Ed, would you like to comment on this?
Yeah, I think it's interesting that even despite all these new therapies, cyclophosphamide still has an important role, I think. And I still use it in my clinic. Would it be fair to say that some of the patients that we're talking about in this statement wouldn't have been in the trials for belimumab and anifrolumab? They're more refractory, more severe patients who are inpatient hospitalized, these sorts of patients.
Yes, indeed.
Yeah. Okay.
So let's move to the and we started dealing with the domains of lupus. The skin disease, it's a challenging aspect of lupus, especially when at the same time we acknowledge that the more data, the stronger its data were with anifrolumab. So the treatment of active skin disease should include topical agents, antimalarials, and systemic steroids, methotrexate, mycophenolate, or anifrolumab and belimumab, considered as a second-line therapy. This is the statement. Ed, any comments on this?
I mean, I suppose that I think it's for us who are not dermatologists, too important to learn how to use the topical therapies well, actually, because we, as rheumatologists, we may not know it as well as our dermatology colleagues.
Okay, so think of the biologics as a second-line therapy, especially the strongest data are with anifrolumab, and there are some impressive responses.
I'm impressed too, yes.
With anifrolumab in patients with severe cutaneous lupus. In reference to the neuropsychiatric lupus, nothing changes. There's not much data. It's the same statement. If we think that the neuropsychiatric manifestations are attributed to lupus, we use steroids and immunosuppressive drugs, or if it's thrombotic, use antiplatelets, anticoagulants, and there is no departure from the previous recommendations. This is a black box of lupus. Anything to add on this?
Again, I suppose the reason it hasn't changed is because we often exclude neuropsychiatric lupus from clinical trials, don't we? That's in the trials of belimumab and anifrolumab and many other new drugs, severe neuropsychiatric lupus is excluded. So we still have little evidence.
That's a good point. There's an unmet need in lupus. Trials for neuropsychiatric disease, as Ed suggested. Hematologic disease is becoming more prominent, especially in large centers. MMF has won some publicity after the New England Journal of Medicine paper suggested that it's effective in immune thrombocytopenia. And this is a statement for acute treatment of severe autoimmune thrombocytopenia, high dose of steroids, intravenous globulin, rituximab, cyclophosphamide, and followed by maintenance therapy with rituximab, azathioprine, or mycophenolate and cyclosporine should be considered. So here we're discussing more the mycophenolate. There are good data about the rituximab that works. I'm not very impressed with azathioprine, but or cyclosporine. I think, after rituximab and the gamma globulin, MMF has made it's an important step forwards. Ed, any comments?
I agree. I suppose one thing I think is in the UK, we have a high level of use of rituximab, but would it be right that in other countries outside the UK, there's more use of rituximab for this manifestation than for other features of lupus? Do you think that's correct?
Yes, indeed. This is correct.
This is like your practice. Yeah.
Yes. So let's go to Friday's initial therapy. Here, in this statement, I would like to draw your attention to two things. There are two types of drugs, MMF and intravenous cyclophosphamide. We're referring here to the Euro-Lupus regimen. We state should receive, and whereas with belimumab or CNIs, from the beginning should be considered. And this is why did we do this? This is not because the data are weaker. There is very strong data suggesting that belimumab or calcineurin inhibitors can be effective from the beginning. But there is always the risk of overtreating, and these therapies are not expensive. So that's why we made this distinction. I guess as time goes by, probably these drugs, the biologics and CNIs, will be introduced pretty much in most patients with nephritis. But I just wanted to highlight why we decided to use this different language. Should receive versus should be considered, because they are not cheap. Ed, is that clear?
Yeah, I mean, I'm using them more. And do you think that if we have limited use of these drugs, we should try to identify the patients who are the highest risk for the combination and maybe the lowest risk receive mycophenolate?
You're talking about the mycophenolate.
Yeah, I was wondering if we should try to, based on the patient's characteristics, like the biopsy, the clinical features, the other lupus features, we should try to select, does this patient need one therapy or two therapies? Do we have the evidence to say this yet?
No, we have some circumstantial evidence suggesting that some patients, there are some high risk, I guess, Ed, you are referring to this, that younger lupus patients who have a very active nephritis, who have a very high active serology, they are more likely to relapse. Therefore, these are the patients who have, who may be the first candidates to use these drugs, if this is what you're referring to. And whereas patients with milder disease, you could use them after the first 3 months if they have not responded adequately.
Yeah, that's what I was wondering, although my preference would be to give combinations to all my patients if I was able to.
Yes, indeed, because the Benlysta has, it's safe and reduces the risk of flares, which increase substantially the risk for organ damage to the kidney, as there are many studies suggesting.
Yeah.
So what do you do after the first initial therapy? And after the initial therapy, following the renal response, if the patient is improving, and we have defined that, the patient should receive for at least 3 years the following. If these patients were initially treated with mycophenolate alone or in combination with Benlysta or a CNI, they should remain on these drugs. The evidence is 1A. Whereas mycophenolate or azathioprine should replace cyclophosphamide for those initially treated with cyclophosphamide alone or in combination with belimumab. And the reason for that is simple, is cyclophosphamide long-term use causes sterility, and that's why you like the subsequent therapy to discontinue and use another agent as for the follow-up therapy. Ed, is that clear?
That's right, yeah. And I think I was talking to Brad Rovin on a podcast recently, and he was saying that although the original EULAR study said cyclophosphamide followed by azathioprine, that doesn't mean we have to do that today in 2023. We can kind of combine EULAR and then with mycophenolate maintenance.
Yes, indeed. That's a good point. So let's go to the next one. Statement, and we felt that there is in patients at high risk, we have to again not to think of high dose of cyclophosphamide, not the EULAR regimen. And how do you define these high risk patients? Patients with reduced GFR, severe activity, and high chronicity. The high dose NIH regimen in combination with parts of methylprednisolone can be considered. There are strong data supporting it. This is a small population of lupus nephritis. In our centers, like in 1 in 4 or 1 in 5 patients. I think this is a good drug, and most of us agree that you use this drug because for a short period of time, it's very effective. And if you combine with belimumab and you subsequently use MMF, you can spare a lot of the toxicity. But Ed, any comments on this?
One of the ideas here, I suppose, is that we don't, when we look at the biopsy result, we don't just ask, is it class 3, is it class 4, is it class 5? We actually have to look a little bit more detail at some of the other features, like interstitial inflammation is an important predictor of outcome, isn't it?
So the histology involved both, as you said, activity, crescent of fibrinoid cross, but also chronicity, interstitial, including plasma interstitial inflammation, which is becoming more important, but also interstitial fibrosis and tubular atrophy. These are the chronicity features.
Yeah.
So
again,
just think.
Sorry.
Please.
I was just going to say that again, it emphasizes that it's always valuable to do a biopsy Even some people say, if you're going to start mycophenolate, why do you need to do a biopsy? But actually, it's very useful to understand the level of risk of the patient, the particular features already present at baseline, how much scarring, etc.
That's an important point. And as in previous recommendations, we have a low threshold to perform an initial kidney biopsy. The issue of biopsying after the therapy is a little bit more contentious, and this is requires more discussion. But low threshold of renal biopsy allows you to take a very accurate look at the kidney, and so you know what you're treating. Because many times if you don't do it, you don't know what you're really treating. This is the point that Ed was trying to make. Of course, after you treat, you have to taper immunosuppressive therapy and corticoids. We try to taper the steroids first because of the risk for toxicity and the damage. And for the immunosuppressives, initially there was a lot of enthusiasm about decreasing the immunosuppressive therapy in lupus patients, but the data becoming clear that you do not you may have to wait a little bit longer, but for the steroids, you can taper them and even discontinue them. Now, there is a study which we discussed, Cortilup, where abruptly they discontinued the steroids. They had flares, and which were mild to moderate. The point I take from there is it's not to discontinue the steroids, but you do that gradually. Don't do that abruptly as they did that in this protocol. Ed, any comments on this?
You think that, just thinking back to the previous guideline as well about steroid dose, do you think all patients should try to achieve 0? Or do you think sometimes it's better?
Most patients, yes. Especially young girls, if it's young women, women in their 20s or 30s, can you imagine a woman taking for the rest of her life corticosteroids? Yeah. I mean, the skin will be terrible, the bones will be terrible, the cataracts. There's a lot of toxicity. So I think it's an ambitious goal that we need to target, I would say.
I agree.
For antiphospholipid antibodies, there is no change. These patients should be managed with long-term vitamin K antagonists after the first arterial unprovoked venous thrombotic event. And the low-dose aspirin should be considered as primary prevention in lupus, non-APS patients with a high-risk APL profile. And the high-risk profile is triple positivity or double positivity, or these are well established. So the data are weaker for the aspirin, for the thrombosis, for the phospholipid antibody, for the vitamin K antagonist, the data are much stronger, 1BB. And we're not using these new NOACs, the new oral anticoagulants, because they may not be as effective, at least for the arterial thrombosis. Ed?
Yeah, that was going to be my question, actually. Yeah, so you answered it already.
So we're coming to the end slowly, so we can have some discussion. These are the key points, the take-home messages. Together with these EULAR recommendations, there was a how to treat lecture at the EULAR guidelines. And these are the key messages. Early diagnostic treatment is essential. The SLERP is an important tool to ensure early diagnosis. It's important to do the kidney biopsy and to stratify the patients according to the risk for flare or for end-stage renal disease in case of nephritis. Steroids save lives, but at the expense of excessive collateral damage, and we're becoming more and more aware of this. The steroids are better for short-term use as a rescue bridging therapy, but may use in some patients at 5 milligrams per kilogram per day, not 7.5 as the previous guidelines. This reduction saves a lot of toxicity. We target remission, not or low disease activity, but with prednisone now, as compared to the previous recommendations, less or equal than 5 milligrams per day. Biologics enable the steroid tapering while achieving remission low disease activity. in more patients with less flares and damage. And this is we're becoming more daring with steroids because of the availability of the biologics. If used early, the biologics, you may have better responses and less damage. There are increasing data supporting that the early use of biologics will be more effective, like in other areas of rheumatology. And an important practical point is that to measure disease activity and damage and audit quality of care. And EULAR has some recommendation quality indicators, a checklist to allow you to know that the lupus care is optimal. These are the key, take-home messages. Ed?
Yeah, and I think just to reflect, I think these guidelines have got a lot of important new messages about the specific organs and the new drugs. I suppose one thing I was thinking is, now that we have new guidelines, how do we make sure the guidelines get followed in clinical practice?
This is a very good point, and it's just complying with them and adherence and part of the patients was discussed extensively. During the deliberation, we felt that we could use the EULAR quality of care recommendations as a checklist. So as you do in the UK, and you have pioneered this, to my understanding, is that you have nurse practitioners who audit the clinic, or they have more time, because we have seen that the physicians are more likely to comply with the treatment guidelines. But as far as the monitoring or follow-up guidelines, they are not very good. And also for adjuvant measures such as osteoporosis, screening for vaccinations or cardiovascular disease and prevention, we're not doing as well as good. So this is creating these checklists and having nurse practitioners audit the clinics and just making sure that these are being done may be a way. What do you do in the UK, Ed?
Yeah, that's true. I think audit is important. And another thing that's happening in the UK is there's more emphasis on treating lupus patients in specialist centres, where people are very familiar with lupus care, or physicians who have an interest in the disease, especially when they're more severe or they need biologics. And then the other question, of course, at the end of any guideline is, this is a big advance, but also we always think about what are the next questions. So what are the areas that we aren't so clear in the evidence, or the trials or studies that need to be done, or what's the research agenda? What do you think are the most important questions now?
I guess it's not as fancy, but it's a practical need and an unmet need. I think we need to assess better the traditional therapies and to know how good or how bad they are. We've been using them a lot, but there is we don't have good quality data to measure their effectiveness or toxicity. That's an unmet need. The other thing is this notion about the early use of biologic therapies. How much will decrease the damage and how much it will change the natural history of the disease is an unmet need. And the final thing that we discussed already is the neuropsychiatric lupus. There's a black box, and it's a difficult area to study, as you know, Ed, but it's we need to do more studies there, because they are measure cause morbidity and mortality.
Yeah, that's what I was thinking, that we need. One thing from your presentation that I saw was that the evidence for some manifestations of lupus is much weaker. So neuropsychiatric is one, but also some of the other organs, maybe the less common organs, like the gastrointestinal involvement or some of the cardiorespiratory features, aren't so common in the trials of the biologics. and maybe we need different sorts of trials to tell us about those organs. And I also, the other thing I was thinking while you were speaking was that another big question that's arising now is how long do we need to continue the therapy? If it's a high-cost drug, like a biologic therapy, then if the patient's been in remission for 3 years, do we stop it now? Do we continue? Do we know?
Yes, indeed.
Okay, so I think that's about all that we have time for today. So thank you very much for joining me, Professor Boumpas. It's so great to have your insights as the lead of this project, tell us into not just what the guidelines are, but why they changed and what they mean in practice. So thank you very much for your presentation.
I was delighted having this conversation with you. Thank you for the opportunity.
Thank you. And thank you to our listeners for joining this special broadcast brought to you by the Lupus Forum. The Lupus Forum is free to access. All our content, including this podcast, is free to download at lupus-forum.com. And don't forget to register for updates. You'll receive emails when new content is made available. You can also follow us at Lupus Forum, all one word, on Twitter and LinkedIn. So thanks again and see you next time.